Good afternoon and welcome, everyone. I'm Constance McIntosh. I'm the Acting Scholarly Director for the McEachern Institute for Public Policy and Governance at Dalhousie. The McEachern Institute is based at Dalhousie University, located in Kjipuktuk, Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq, where sharing takes place pursuant to the peace and friendship treaties. And these lands are also ones where African Nova Scotians are a founding people, whose distinct culture and social and political practices have and continue to contribute to shaping the story of this province and its future. Today's panel, which is co-sponsored by the Canadian Centre for Vaccinology and Dalhousie's Health Law Institute, considers one of the new strategies that some states are using to try to navigate their way through the COVID-19 pandemic. We've already seen the widespread adoption of vaccine passports as a requirement to participate in certain activities, as well as workplace vaccine requirements. And more recently, some governments have begun to impose fines or taxes on the unvaccinated. Austria fines unvaccinated persons around $5,000 every 3 months. Singapore, which like Canada, has a universal healthcare system, it's now billing unvaccinated people for hospital stays that are related to COVID-19. With Quebec's announcement 2 weeks ago that it plans to impose a tax on unvaccinated people, and a national poll this week where 60% of surveyed Canadians expressed a level of support for vaccine fines or taxes, these policies are now on the discussion table here in Canada. I'm going to introduce you to our expert panel now. They're going to explore the medical and ethical and policy issues that are raised by practices such as taxing or billing unvaccinated persons, as well as the viability, desirability, and legality of such policies in the Canadian context. So each panelist is going to present some opening comments, and then we're going to turn to discussion. And I ask those of you in our audience to please use the Q&A function to identify questions you'd like to see posed to the panelists, and ideally, maybe even suggest which panelist you'd like to see answer the questions. So first up, we're going to have Dr. Lisa Barrett. Dr. Barrett is an infectious disease clinical specialist. Her work engages the clinical and immunological aspects of COVID-19. So welcome, Dr. Barrett.
Thank you so much, and really looking forward to chatting about some of the medical and infectious disease parts of this topic. Now, if you haven't heard of COVID-19 and the virus that causes it at this point, we better start somewhere else. But I'm going to assume that everyone out there listening today has some knowledge of this virus. It is an RNA virus, so its genetic material is somewhat unstable. It can change over time, and it is spread from person to person, importantly for the rest of this discussion, I think, via a respiratory mechanism. And by that, I mean that it travels in droplets from our airways into the air around us and can spread to other people. And so infection in this case is not just something that happens to a person, it happens to the people around us as well. Now, as we've evolved through this particular pandemic, what has become clear is that this virus, the way we would expect it to, when it's new to the human species, it has changed from alpha to beta. We've all gotten a great lesson in Greek alphabets forward through to now Omicron. And Omicron, as a respiratory virus, has a couple of key features to it that are different from previous versions. Number one, it is very transmittable. And we know a little bit and we surmise a little bit more about how exactly that happens. But essentially, it does seem to infect people quite easily in the upper airways, and also to move between people more easily than previous versions. Now, two key things here from a medical perspective about Omicron compared with Delta. Number one, this transmission and transmittability means that also we think it is a dominant virus that grows and infects different tissues than before. There is some evidence that it may actually not cause as much disease in the lung tissue as previous versions for most people, although there are still some very, very vulnerable folks who exist in our communities and populations. The second key and core part of Omicron that I think is important is that it, in addition to being very transmittable and slightly different in where it causes disease and how serious that disease may be, we do know that vaccines do work against this particular virus, at least the ones we have available right now, but they work a little differently. It's likely that you need more doses in most people in order to get the same kind of protection against infection as opposed to protection from death and hospitalization. So this brings us to the next medical piece of COVID, respiratory viruses, and vaccines, which is that there are two aspects to this. We're just getting natural immunity in our communities through different types of exposure, as well as protection that is developed and consistent through the use of vaccines. And those two things, both immunity through exposure and vaccines, also alter the way that this virus infects and actually affects our populations. And germane to the next part of the discussion about how vaccines are rolled out in different groups and populations, I think it's useful to just pause for one moment here, and this will be my last comment before we move on. I think it's important to note that we look after people as well as populations. As a medical doctor, I look after the person in front of me, and I'm aware that with COVID-19 as a virus, there is a large number of people with Omicron or Delta who will do okay if they get infected, regardless of their immune status. However, some folks are going to still spread to other people, and that's an important factor here. Vaccines reduce that spread among even the very immunocompetent people. However, they do not completely preclude it. And I think we need to recognize that. And number two is that there are still vulnerable people who come into your office who are patients and people that are infected in our populations. And no matter what we do, we can't completely protect those people from severe disease. And for that reason, we do look at what the ability is to reduce their risk, both at their own individual level through vaccination, as well as at a population level through spread from other people. And that also involves larger numbers of people around them being vaccinated. So I think the person, the virus, people, and populations all intersect here from a medical perspective in an ever-changing way. And at this point in our pandemic with a new pathogen, we are still trying to figure out exactly the right way to protect both the vulnerable and the less vulnerable. And vaccines are a good way to do that in our population. So I'll pause there.
Thank you. Thank you so much, Dr. Barrett. Yeah, this conversation really is about, as the pandemic changes, as our evidence changes, how should our practices be shifting with that? I appreciate your foregrounding that. And now I'd like to introduce Dr. Gaynor Watson-Creed, who is an assistant dean with Dalhousie's Faculty of Medicine and a public health specialist who in the past served as the Deputy Chief Medical Officer of Health for Nova Scotia. So welcome, Dr. Watson-Creed. You're muted.
That would be better. Thanks so much for that introduction, and to Dr. Barrett for those opening comments. So I think I am probably going to take us straight into the conversation about this question of a vaccine tax or the vax tax. And a couple of things I would say with respect to that. You'll get no argument from me that in general, vaccine mandates work to increase numbers of people vaccinated in the population. And we didn't need COVID-19 to tell us this. In fact, we saw this in Canada from vaccine mandates that, for example, are applied in Ontario under the Mandatory Immunization of School Pupils Act, where we see that by the application of that act, we get an increase in the number of students reporting their immunizations, preschool immunizations before they enter school. We saw it with influenza strategies in that same province over many years. And in the US, we see this in, for example, university populations who are required to provide proof of immunization for a number of things, and in workplaces as well. And we see that that works to increase the number of people who get immunized. You'll also get no argument from me that for this particular disease, we have a vaccine that works. And using that vaccine, as Dr. Barrett has pointed out, to reduce the number of people who will remain vulnerable to COVID-19 is critically important if we're ever going to see the end of this. That's an absolute imperative for us. But yesterday evening, I did spend some time, sort of polling some public health colleagues across this country just to get a sense of what is the current thinking around this proposed vax tax from the province of Quebec. And I got, on the whole, I would say, what I got back from my colleagues was something that sounded like confusion. So everything from, wow, seems like it could be a slippery slope, to, I don't even really know how that would work and how it would be implemented, to, yeah, in our province, we're basically not even talking about it because we wouldn't even know what to say. And I admit I came into this panel discussion feeling the same way, and probably still feel the same way, for a few reasons. I think what troubles me about the conversation that's unfolding in Quebec is that I can't find the public health principles that it stands on. And I think the application of public health principles for something that has the potential to impact so many members of the population, and particularly their capacity to sort of equitably access healthcare is a really important one. And so some of those principles look like this. When we talk about why people don't get vaccinated, there are a number of reasons that come forward. And so it's not only fear of the vaccine that can drive people away from getting vaccinated, although that's an important consideration. And in many ways, one of the easiest ones to tackle, if you can give those people the right information and the right opportunities to interact with the healthcare providers who can shepherd them through the process of becoming comfortable with the vaccine so that they get vaccinated in the end, which is the ideal situation. And then they're protected and those around them are protected. But we also see sort of this long list of reasons that people may avoid vaccines that has nothing to do with their fear of vaccine or their fear of being harmed by the vaccine. And we call those, in sort of the, sort of the literature around risk and how people perceive risk, those are called non-damage attributes of risk. So these are the things, aside from damage from the vaccine, that people might be afraid of, that they might also be afraid of in coming forward. And they include things like, well, if I feel like I'm being told this instead of being asked to engage in it, that has me get my back up and I don't want to participate. And so is it voluntary or involuntary? It includes things like, maybe I've heard of a catastrophic instance of something happening with this vaccine. That's very unlikely with COVID-19. The vaccine has rolled out, in so many hundreds of millions of doses around the world, and we're not seeing that. But it's a fear that people may hold, and it may prevent them from coming forward. And the other one is, there's a lot, but another one that I point to is whether or not they trust the people who are bringing forward the idea that vaccination must happen. And it's one thing when those people are MDs, and that, when I'm giving talks about risk, what I often say to folks is that, physicians often have an advantage because we often are trusted by the public. It's very different when it takes the flavor of being imposed by government. And I think throughout this pandemic, we've tried to walk a line of the public health folks sort of bringing those public health principles and practices to play wherever they can, and government being clear that that's not theirs to do, and then government stepping in where they need to step in. But when it's unclear, I think the public gets anxious. And so I think it would be important to acknowledge that a vax tax is not going to decrease the suspicion that, for example, some people in Canada have about Canadian governments. And I know you're shocked that people are suspicious about Canadian governments, but there are, of course, sectors of our population who are quite suspicious of government. And I'm not sure that the tax reduces their suspicion. Quite the opposite. I think it may increase their suspicion. And so I'm not sure what we gain then by adding the tax into an already kind of suspicious environment, if I can put it that way. So that's one set of principles I would point to. The other set of principles that I might point to is, the idea that of all the measures that we would take, this tax and taxing individuals would be the thing that we would do. So we do use taxes in public health to shape community behavior in a number of different ways. We tax cigarettes, we tax alcohol. In Newfoundland, they've recently announced that they'll be taxing sugar-sweetened beverages. And we know this is a proven strategy in public health to reduce access to products that we think are, that we know through the scientific evidence we have often over decades are universally harmful to populations and really have no benefit to offer those populations. But in those cases, we're taxing the product. We're not taxing the individual. And so I think this is part of what's confusing myself and my other public health colleagues around this proposal, is that when you talk about taxing the individual, what you're really talking about then, I think, is a fine. And so if this is going to be a fine, then I think label it as a fine, and then think about all the ways in which the fine may or may not actually get us to that end goal, which is wanting to have an increased immunization rate in the population at large. The last thing I'll say is that, when we approach using any such measure in public health, we always are looking at what are the alternatives, what are the different ways that we can continue to sort of coach the population of interest along to the outcome that we know is best for everybody. And yes, we will use coercive and restrictive means, but not as a first approach. And appreciating that we've been in this pandemic now for 2 years, and that there was a lot of impatience with those who are unvaccinated, which I completely understand. I do wonder about, even in public health, I think we recognize that there is a limit to the to our use of restrictive means. We've not talked about, how what we think those limits might be around COVID-19, or at least I don't think it's been part of the public conversation. But there's a point at which even the most restrictive means just don't make any sense anymore, because the benefit from them may be outweighed by the harms that they create. We're always looking at that in public health. And I haven't heard that conversation about this proposed tax yet in Quebec, at least not from sort of the government of Quebec in those publicly available means. I am hearing, for example, colleagues in ethics and others bring some of those conversations about risk benefit forward. So I think all of those things would need to be in the mix in order for certainly public health professionals like myself to feel confident in this as a move. And we don't have them yet. That's not been part of the dialogue, at least not as far as I can tell. And so, on the whole, I would say my confidence in this as a strategy would be low for those reasons.
Thank you so much, Dr. Watson-Cree. That was super interesting information, and getting a little bit of insight as to the conversation that's going on across the country is really helpful, I think, for us here today as well. We're going to turn now to University Research Professor Françoise Baylis, who is a member of the Order of Canada, and she recently received the Canadian Bioethics Society Lifetime Achievement Award. So over to you, Dr. Baylis, for some insight into the bioethical side of this.
Great. Well, I'd like to actually build on what you've already heard and have as my starting point that I worry that the strategy of taxing people, or as has been suggested, truthfully, fining people for failing to make the right choice, and I'm putting right in scare quotes here, to be vaccinated, may not have as meaningful an impact on terms of numbers as people hope, and it may in fact have a very high negative impact. So I want people to think about how likely are you to change the behaviors, which is the strategy or the goal here, and at what cost. So one of the things I worry about, and we've already heard mention of this, is the way in which this kind of policy can have a disproportionate impact on different communities. And so, for example, we know that some of the people who are vaccine hesitant have certain concerns based on a history of a less than positive interaction with the healthcare system. So we need to work with those communities in a way that's helpful so that they can voluntarily choose to come forward and to seek vaccination, as contrasted with trying to force them to proceed with something that they're not comfortable with. And so I worry about the ways in which we're using a financial penalty to try to achieve a goal that would be better achieved by other means, such as respectful, engaging conversation. I'm also worried about this idea of a flat tax, if you will, because that will disproportionately have an impact on low income earners. So Premier Legault has said that the tax would be significant. The example given is that it wouldn't be $50 or $100. And if we look at other places that have introduced a tax, the amounts are in the thousands of dollars. Well, if your income is about $20,000, $25,000, a $2,000 tax is a tremendous amount of money. If your income is $200,000, a $2,000 tax could be perceived as insignificant. So you would get, as a matter of principle, to act on your views, but somebody else with a lesser income might feel more coerced into making a particular kind of choice. So when we introduce policies, we need to think through clearly how they can have a differential impact on different communities. One of the other things that I think is really important to think about is how this particular approach potentially undermines, or I would argue in this case, further undermines trust in government. And I worry about the ways this kind of a policy can be redescribed by people who would fall into the category of hardcore objectors to vaccines, as contrasted with those who might more reasonably be called vaccine hesitant, and embolden them to say, well, look at what your government's trying to do. They're riding roughshod over all your civil liberties. Can't people consent to treatment? And I think that is actually something that's been pretty fundamental to the way in which our government-funded healthcare system works, which is that we trust people to make their own healthcare decisions, provided they're perceived as competent individuals. And so in that context, I think it's worth thinking about what kind of a precedent are you setting if you say, well, this is one area of healthcare where you don't get to make your own choice. Your choice has to align with the government's choice. Now, please, I don't want to be misunderstood. I completely support the public health goals. I am not advocating for autonomous decision-making at the expense of the common good. What I am saying is that we need to think about what it means to set a precedent to say, in this particular case, your government will not allow you to make a poor choice. So I think it's a poor choice to decide not to be vaccinated. I'd like to help you change that choice. But I don't want to do it in this kind of a draconian way where I say you're going to have this significant financial penalty unless you do as you're told. So I worry about the mechanism being chosen. I don't disagree with the goal or objective, which is to increase the number of people who consent to be vaccinated. And I guess the last thing I'd like to say is sort of part of the opening remarks is I worry about the cost of actually implementing this kind of a program. And I want you to think about it in terms of the actual financial cost, in terms of actually collecting the money, et cetera, and having to enforce it if you have people who conscientiously object and choose not to pay this particular tax. But I want you to also think about it as a cost that's being borne by people in a way that maybe we should be spending that money differently. So it's costly to implement, both in terms of dollars and cents, and also in terms of impact on the community. And maybe, and this is a controversial idea for some, but I want to put it out there so that we can have a conversation about it. Maybe we're reaching a point in time where we actually have to accept that a small percentage of the population is always going to be vaccine resistant. They're not going to want to be vaccinated. And maybe we have to actually think about accepting that as a reality and turning around and thinking about what we could do instead. So one thing is maybe we could actually be systematically funding the distribution of N95 masks, because people who don't want to put something into their body might be very willing or able to wear a mask. That would help with the overall public health goal. And maybe if we actually were to think about it in terms of we've reached a point where some Canadians do not wish to be vaccinated, maybe we could seriously turn to the objective of helping to vaccinate the world. There are people who want these vaccines and don't have access. We've been told repeatedly by the World Health Organization and by epidemiologists and medical doctors around the world that we will not end this pandemic until everyone is vaccinated. And so it's in our best interest to get the vaccine into those who want the vaccine. And maybe we just have to accept that there will be a small percentage of Canadians who will not be vaccinated.
Okay. Thank you so much, Dr. Bayless. So interesting that you've taken us to the international sphere and that context, and how that then plays into the situation here in Canada and what we're trying to achieve locally. I'm going to pass the mic now to our fourth panelist, Colleen Flood, who is a research chair in health law and policy and the director of the University of Ottawa's Centre for Health Law Policy and Ethics, who I know also serves as the scientific director for the CIHR. Over to you, Dr. Flood.
Hi, everybody. Actually, that was a while ago, Constance, the CIHR. So I don't want the current person thinking I'm trying to just take their job back. Nope, you can keep that for sure. So thank you very much, Constance, and to everybody for inviting me to speak on the panel today. I have a couple of thoughts to give you. I thought I'd start with whether or not such a tax is actually would be legal. So I thought I'd start with that, and then turn to some of the questions about whether it's ethically defensible, and then finally whether it's good policy. So we'll see how I get through. I think, an important caveat on all of this is that a lot of the devil is in the detail, and we don't have a lot of information yet about what it is that is actually proposed. And so we have to keep that in mind. So first, the question is whether it would be legal. And I would note that this would not, as it's at least as we hear about it in the media, would not contravene the Canada Health Act. It's not related to one's consumption of healthcare services. So, an unvaccinated person may be fortunate enough not to have any ill effects from COVID and not cause any impact on the healthcare system, but they would still have to pay the fine. So it is not related to healthcare consumption, and so it would not jeopardize or put in issue the Canada Health Act. So I've seen a lot of discussion about that, usually wrong. So then second, turning to the constitutional issues, some worry that such a proposed tax will financially coerce people into undergoing a medical procedure, and that this interferes with Section 7 of the Charter rights to life, liberty, and security of the person. Now, we could talk about this for about 2 days straight, I think, but I think the short and almost certainly correct response is that Section 7 of the Charter does not protect economic interests of the sort proposed by a tax. And this is a point that the Supreme Court has reiterated many times. Now, in some cases, the court has expressed openness to the possibility that economic deprivation, which threaten a person's very survival, might engage Section 7, but there are really no indications that Quebec is proposing anything so severe. And by some reports, they are proposing that they'll have exemptions for low-income people as well. So those opposed to Quebec's tax might say, well, perhaps we should be protecting economic interests under Section 7. But I think you have to be careful what you wish for here. There was a period called the Lochner era in the US where the Supreme Court there intervened to strike down laws that interfered with so-called economic rights. And the results were appalling, overturning child labor laws, minimum wages, workplace safety regulations, and so on. And I think the Canadian Supreme Court has wisely steered clear of those kinds of shenanigans. So I think it would be legal. So the second, but being legal doesn't make it right, So then the second question is it ethically defensible? And I think here, context really matters, and the context of Quebec matters a great deal to this discussion. They have not performed nearly as well as you have in Nova Scotia or the rest of the country, death rate from COVID-19 per 100,000 people is 141 people have died per 100,000 people, compared to the Canadian average of 81 per 100,000. And of course, it's much lower in Nova Scotia. And Quebec's hospitals have been strained to beyond belief. And half of the ER beds are occupied by those who are unvaccinated, even though they only comprise 10% of the population. So this context, has to be considered. Where are they at? And what are the dangers on the other side? Now, I think, a very important point is whether or not it fails from an equity perspective. And Stats Can, and Francoise has been very articulate about this as well, that some of Canada's racialized populations have lower vaccination rates than the Canadian average. And this is, of course, a worry and something we must work on. But I think there are even stronger equity arguments when you consider the other side of this, when you look at who suffers from COVID-19, who will be harmed if we don't do a better job at getting everybody vaccinated and taking other measures. So if we look, for example, in Quebec, in Montreal, for example, the mortality rate was 149 deaths per 100,000 in areas with the highest percentage of Black Canadians, compared to 88 per 100,000 in areas with the lowest percentages. That's almost double the death rate in areas with Black Canadians in Montreal. And we also have to consider that those who need healthcare right now, who can't get into the hospitals because of people occupying the hospitals right now, these are the most vulnerable, because unfortunately poor health is often associated with lower socioeconomic incomes. So when we're considering the issues around whether it's vaccine passports, vaccine mandates, taxes, I think we do have to consider what's on the other side of the ledger. And these are real people who have died, who are suffering, their families. If you think about the intergenerational trauma of early mortality, it is very significant for those families and not something to be easily recovered from. So I think, Francoise is completely correct. We must think about the counterfactual here. What are the real policy alternatives that the Quebec government has to achieve quickly, and I think that's the issue, quickly increases in the numbers of people who are vaccinated to try to avert some of this carnage? And some of the policy options that are available to quickly achieve this, lockdowns, curfews, schools and business closures, all of these things have their tolls too on vulnerable communities. And so those have to be considered as well. But finally is the question of whether it's a good policy idea. And here I agree with my colleagues. I'm not so sure that this is just a good policy idea, but for a different reason, I think, than they do. I suspect that it likely won't come to pass. That's the first thing. I think it's going to be administratively difficult to put in place. And by the time that it actually comes to pass, we will be past the Omicron wave. So then the question is, is it actually needed at the point that we're talking about when it comes into play? I don't think it will have the same sort of incentive power as, for example, not being able to go to a restaurant or a pub or whatever it is, as opposed to paying some level of tax in the future. So I think administratively it's going to be very difficult to do, and it's unlikely to happen. I mean, we'll have to see. Maybe the fact of announcing the tax will have some impact on uptick in vaccination rates, but I suspect it will be very little. But I just want to close by saying, overall, I worry some about how we in the ethics and law community approach these questions. I find that we're very good at criticizing and condemning policy options and talking about the rights and interests of the individuals affected by the policy options. but not very often about the other side of the ledger. It's sort of obliquely public health or whatever it is. And I just want to reiterate that the numbers on the other side, who are dying, and the people that are dying, and the people that are being impacted by COVID-19, these people matter as well. They matter as well. And we have to consider both of these interests. So I'll leave it there.
Okay, thank you so much, Dr. Flood. That was really interesting contextual pieces, and thank you in particular for taking us to Quebec and highlighting the facts of what's going on there, and how that might change the analysis somewhat in that location, perhaps not. Our other panelists may have a view on that. I'm going to pose a few questions to the panel now, unless someone would like to immediately respond to someone else's comments. I just want to put that out there. And I'm going to invite audience members to to type questions into the Q&A, and we'll try to get some of those asked as well.
Constance, if I can, I'd like to make a brief comment. I really want to emphasize a point that Dr. Flood made, which is the importance of being able to achieve the goal quickly. And I think one of the potential problems we need to think about with the proposal for taxes is I'm not sure there's enough of a connection between the policy objective and the mechanism that's being proposed. And the reason I say that is I'm assuming there'd be no intention of applying this retroactively to the 2021 tax year, because that would seem unfair. So we'd then be talking about the 2022 tax year, and then you'd be paying the tax in April of 2023. So I think it's really important that there be seen to be a connection between a consequence of making a particular decision and what you perceive as a limitation on your freedom, or you perceive as a tax or a fine, et cetera. So I think that that's an important thing for me anyhow, that's really important when I think about the costs of this particular strategy relative to the stated goals and objectives. I'd also like to say that I think it is really important that we not simply be critical of things that have been put forward, by governments, but also that we look to offer solutions. And for me, one of the things that's really hard is I don't have a good solution to the current problem of the stress and burden on the healthcare system. I think that that's very real. It has an impact not only on the people who have COVID, but people who have other underlying healthcare conditions and who need access to healthcare facilities to get their treatments. And so we not only have ill health and death as a result of COVID, but also as a result of not having access to the healthcare system. And I think that that's also really important. But I do think, and I really want to emphasize this because I don't think we're doing well with respect to understanding this as a global perspective. And maybe Dr. Barrett wants to comment on this. And Dr. Watson-Creed, that if it's a global problem, we have to have global strategies as well. And so I want to come back and invite the audience to engage with the idea that Canadians need to step up and start giving away vaccine to people that need it.
Thank you so much, Dr. Bayliss. And I think that this is actually a good time to shift the conversation to the global and the local context. And Dr. Flood, I see you have your hand up. And then I'm going to invite Dr. Watson-Creed and Dr. Barrett to also comment if you wish.
Yeah, first of all, I 100% agree that we have to work on ensuring everybody in the world has access to vaccinations and the other, N95s, all the other precautions that we know need to be layered in. But I don't see one is antithetical to the other. If we can't keep our own house in order, if we can't look after our own people, I think, it's a bit difficult for us to run around the world saying to X and Y and Z, what you should be doing. I'm not saying that's what Francoise is saying, but I think we have to be quite careful there. I think we need to be doing both things. We need to be proactively working here to protect the people now in our communities who are suffering and dying from COVID-19. and will continue to do so as this pandemic progresses. And at the same time, get as many vaccines into the hands of as many people internationally as we can. So, I absolutely agree. We need to double down on all of that as well. I think it's ridiculously hard right now for everybody. There is so much going on, and I would not like to be either in government and working in public health, working in hospitals, or being a healthcare provider at this time. This is very, very, very hard times, but yes, we need to do both. I think we should be careful as well to imagine that once we get vaccines, the sort of priority has been, let's get vaccines into the hands of healthcare providers in other countries and into the hands of the more vulnerable in other countries. That is very important, but don't think that they won't experience what we're still experiencing here with 77-80% of folks vaccinated and the variants evading the vaccines. They will still have these problems. And, most likely because the vaccines don't completely stop transmission, new variants will emerge. This is what we have to deal with. We're going to have to deal with this for some time. So even with the goal of vaccinating the world, we are not, unless that is some perfect ability to do that, which obviously we can't even pull off in our own country, these things are not going to go away anytime soon. This issue is not going to go away anytime soon. Sorry.
Thank you, Dr. Flood. We're going to turn the spotlight on Dr. Barrett now.
Thanks. So just to follow up a little bit on that, where we are, not just in terms of geography and Quebec matters and their context, but where we are in the pandemic. And that again comes into the fact that we have a lot of tools, we have a lot of vaccine, but asking the question, how much more vaccination would we need to get that would cause there to be a distinct and significant difference at this point? Now thinking forward to the next piece, coming back to this rapidity question, if we got, then let's assume that a vax tax does that, which I'm not quite certain it's to incentivize people to get vaccinated. If it is, if we get 4% more people vaccinated over the next 8 weeks, is that actually going to make a significant difference to, as has been pointed out, the most vulnerable people, who are the folks who end up significantly disimpacted by or disadvantaged by COVID-19. And I'm not certain that it does make a big difference, even if it were to incentivize and not cause disparity, which is a very big risk with a vaccination tax. So just in case anyone was wondering if I had an opinion on this early on around my initial comments, but I do think it's good to just, let's be clear, again, vaccinations are an incredible tool, but using them in isolation, again, without other bits in that toolbox and recognition that right now we're looking at the biggest issue in the most vulnerable people, we need other things than just vaccination. And even if this particular policy decision were to incentivize people, I don't think it's going to get us there in terms of a maximum impact in a short period of time. B, it may well negatively impact long-term vaccination rates and the ability of people to see vaccination as a viable option for them in the future if they were quote unquote taxed into it right now. And then number 3, I really do think it's exceptionally important that we not forget that there are other things we need to do along with the vaccination at the same time to build confidence and not create disparity amongst the folks who already may have a significant financial disadvantage, and that is linked to their health. And does their health get worse because they then cannot either work or afford food if they're in that marginalized group? So just a few things to think about.
Thank you, Dr. Barrett. Dr. Watson-Cree, did you want to hop in here?
Oh, yes, most definitely. So a few things. I'm really grateful for the very sort of thoughtful discussion that we're having. This whole notion of this tax as an incentive to me is I guess a little bit of a non sequitur, and I think that's why my colleagues and I remain confused about what ultimately this is meant to achieve. So, absolutely agree with the points that there is a heavy toll being exacted on particular populations in the Quebec and in the Canadian context. But, in public health, when we get to that road, often, for example, with individuals who are worried might be transmitting the disease to somebody else, and we want to make sure that that behavior stops. One of the tools that we do have in the toolbox is actually incentives. So I think about the administrative costs of putting all of this together that you've pointed to, Dr. Flood, and go, so what would it take for us to actually incentivize people to come forward to get vaccine? And I think that's been tried in some jurisdictions in Canada during this pandemic. I would be curious if that's one of the policy options the Quebec government is looking at. Can we actually provide people with some kind of remuneration, food vouchers, whatever might be of interest to the populations at hand to come forward with vaccine, instead of going down what appears to be a very punitive route? And so those same populations that are being disproportionately affected by the vaccine have also historically been disproportionately affected by punitive measures from the state. And so there's a way in which this, at least on the surface, looks like it lines up as just another one of those. And so if engagement of the population is what we're hoping to get, my worry would be we're creating actually the opposite, even by the dialogue that's been had so far around this incentive. So I remain confused, but also have more angles, I guess, to think about in my confused state as this conversation goes on, because it clearly is not a simple proposition.
Can I just jump in, Constance? For
Of course, yes.
So, Gaynor, as you know, that many Canadian jurisdictions are trying incentives through the use of vaccine passports to access non-essential services, and we saw, a very quick uptake, and the evidence is coming in now that they have worked to increase the numbers of people who are vaccinated. So, and I think when it's all said and done, we'll see that saved many people's lives, that incentive. And I think many of the comments you've made, though, were also made about the introduction of those vaccine passports, as the same sort of critique was made. So it's a question of degree, how you go down here. And I think really importantly, will it work or not? I think that's the question. And I tend to agree with you. I don't think it will have the impact. And with Francoise, I don't think it will have the impact. But I think, Lisa, on your point about, fines and taxes and impact on the marginalized, I mean, we do this. And I think I disagree with your, Gaynor, that there's any difference to say we tax the product as opposed to taxing the person. We tax cigarettes, and the disproportionate number of people who consume cigarettes are very low socioeconomic income across Canada. And, a very large proportion of their income, once addicted to cigarettes, goes to paying for those cigarettes. And we are fine with that. Because we know the evidence is also really strong that taxation of cigarettes has reduced overall the consumption of cigarettes. And so those people that are addicted, consume cigarettes, we make them pay that tax. It's basically a fine. And, we're okay with it. So I don't think that there's a huge kind of moral, to me, difference between those two things there. So you want to jump in, Gaynor?
So I'm going to thank you, Dr. Flood, and we're going to invite a response from Dr. Watson-Creed. I've noticed that a lot of the comments that people are making are in fact responsive to the really interesting questions that are coming in, but I will pose some questions out of the Q&A after we hear from Dr. Watson-Creed.
Yeah, thank you. And thank you, Dr. Flood, for that. You're right. Those same arguments did come forward with those earlier measures. And yet I think there is a level of incentivization that we haven't reached in this pandemic at the individual level, that we haven't gone there. On the question of, sort of how is this different from cigarette taxes as an example, I think it is actually quite different. So cigarettes are a really good example, because one of the things that we are universally agreed on in public health is that cigarettes actually in and of themselves have zero intrinsic value whatsoever. And so short of removing the product entirely from the market, which would be the ultimate public health goal, I think if we could do that, we would. And Big Tobacco, of course, doesn't want to hear that from us. But if we could do that, we absolutely would, because the product universally has no intrinsic value and creates so much harm. And so the universal application of a tax against it, it does work, sort of to decrease the consumption of that universally harmful product. We're not talking about the same kind of product and consumption behavior here. And so I think this particular consideration deserves a different type of organization before we make decisions on. I'm not quite sure I know what the type of organization is, but I don't think we can say it's the same as that, sort of product consumption conversation that we might have around something like cigarettes.
Thank you so much. So as mentioned, I really appreciate how in the group's comments so far, it's clear that you're reading the questions in the Q&A box and trying to bring them in. One of the questions that we've flagged asks, and this might be a question I'll ask Dr. Barrett to start on, which is there any evidence-based persuasive response that the unvaccinated should take responsibility for the epidemiological consequences of the increased spread of the virus and hospitalization and death? And other people have raised the question of, all of the folks whose, procedures are being delayed by the strain on the healthcare system caused by the continuance of the pandemic. So Dr. Barrett, can I ask you to weigh in here?
Well, I can start with a little piece, but certainly the evidence around the epidemiologic part and the preventative medicine part, I'll leave to Dr. Watson-Creed as well. But in terms of measurement of additional harm caused within a direct health system related situation, there's almost every health system in the country is trying at least to measure what the additional impact is outside of direct COVID related disease on health systems, people and populations right now. I think other countries are having a little bit of an easier time with it in terms of some of the systems in the UK and the NHS, where they have some really great data collection around that. And it's clear that there are impacts. So I don't think the size of the impact and how preventable it was at the given time in the pandemic, I think, is a bigger question. But in terms of, again, you have to come back to that question, I think, of where we were and where we are in the pandemic. That's not an equal thing right now compared to at the beginning. It was much more defensible, if there was a need for defensible to be a word, to do things differently when we had no knowledge, no tools, and no ability to mitigate, other than the most draconian, I think the word was used, of restrictions and precautions. Now we have tools like vaccines, but also other tools that have been mentioned. There's masks, there's other things. We know a lot more. Knowledge is an important and powerful tool, I think, in terms of mitigation of spread. And so I think it's going to be difficult as we go forward at this point in time to really just hang our hats on only one mitigation tool that people have to buy into. What if they do something else? What if they decide to mitigate their risk to others around them and to themselves and their usage of the health system by using other tools? Are we okay with that? And how do we monitor that? Or do we monitor that? Are we going back to a population level? Because we do have enough, and I mentioned this in the beginning, exposure-related immunity plus vaccine-related immunity as a population, that over the next 6 to 8 weeks, we're going to be in an incredibly different spot than we were even 4 months ago, when exposure-related immunity and vaccine-related immunity were very low. Not the way we wanted to get there. And these aren't cases, they're people, to Dr. Flood's point earlier. So that's a long answer to say, I'll let Dr. Watson-Creed talk about some of the preventative medicine type evidence, but there's lots of emerging evidence that there is an impact on preventable illness and disease, not just COVID related, but how we mitigate that, and if a vaccine related restriction like this is solely the answer for mitigation, is not clear to me at this point in the pandemic either.
Yeah, thank you for that, Dr. Barrett. So Constance, I might get you to repeat the question just so I'm clear.
So the question is, there's a lot of many syllable words in this question. Is there any evidence-based persuasive response from the community of experts? So is there any evidence that the unvaccinated should take responsibility for the epidemiological consequences of the increased spread of the virus and hospitalization and death? And so this is taking us to the fact that people's surgeries are being delayed, that people are unable to get routine tests done, and how to balance that with the people who decline to be vaccinated and the consequences of that.
Yeah, I truly, in so many ways, feel like I have no idea how to answer that question. I mean, yes, I think to Dr. Barrett's earlier point, there is a relationship there. But I guess I also think, well, how much of this, these are scenarios that we have been talking about since I started my career in public health over 16 years ago. When pandemic planning was just kind of a glint in our eye, we weren't sure we'd actually have to ever execute on those plans. And we talked then about the need for surge capacity and the need to make difficult decisions around rationalizing ICU beds and all of those things that are playing out in real time right now in Canadian communities. So I feel like there is a story to be told about the impact of the unvaccinated, absolutely. And yes, we are seeing them disproportionately represented in our hospitalizations and ICU beds. And yes, where we have seen, sort of blooms of COVID-19 activity across the country over the past 2 years, it has been unvaccinated populations. And in most circumstances that, it has been where the disease has spread, of course. But there's also a story to be told about how ready have we been as a healthcare system. How much were we paying attention to those lessons of pandemic planning from the early 2000s and revising those plans and preparing for an event like this? That's part of the story as well. So I don't know that any of the Canadian population can hold full responsibility for the outcome that we have here. I think there's a lot of responsibility to be shared, I guess is the point.
Thank you so much. Did either of the panelists want to jump in on this one, or can I give you, one
Well,
last?
I would say we certainly, we blaming anybody, is difficult. I think the question is what sort of choices would flow from that, what policy choices would flow from the fact that unvaccinated people are certainly displacing others who have critical needs. And, I think, Constance, my sort of experience of this is it's much more than just sort of regular tests and things like that. I have a friend who's dying of cancer, and she's, really scared that she will have to die alone without most of her family around her because of what's happening in the hospitals here. And it may be that, as Lisa says, in 6 weeks' time, we'll be in a better situation. But we also know that we've been here before, haven't we? Where we've all thought that and thrown everything out and back on the whirly-go-round, and then we come back out into another variant. So, I don't know that this issue of being vaccinated or unvaccinated is going to go away. I think we're going to have to consider this probably again when and if we get the next variant that comes at us, depending on how amenable that is to either natural immunity acquired through infection or vaccination or combination of those things. And so I don't think we can simply rest on our laurels here. And one of the things that I've tried to advocate for is that we actually prepare ourselves for these things. And, I really congratulate Constance and others on having this conversation. Francois has been really out there trying to lead the debate on these things, because we need to have these conversations so we can understand what our choices are when things go pear-shaped. What are our real options around vaccine mandates, vaccine passports, vaccine fines, taxes, whatever. Sometimes we don't know what the significance of those choices will be until we get to a point where, some new variant is coming at us that is evading our current vaccines, and we have a new vaccine that might work against it. What do we do?
If I can, I'd like to just weigh in and talk about this issue of holding individuals accountable for what turns out to be a communal problem. And I think one of the things that I worry about is exactly this kind of move, because that's not what our government-funded healthcare system is about. And that ties directly into the question of taxation. I mean, we've heard a little bit about, the importance of thinking about the difference between taxing a product versus taxing an individual. But we've also heard that about a very particular kind of behavior. Nobody is talking about, taxing people who play ice hockey, and how many of them, especially as young kids, end up with a concussion and using up resources in the healthcare system. I mean, the point I'm trying to make is we could then start expanding it to all kinds of poor choices. And people won't think of playing hockey as a poor choice because that actually is getting you exercise. But what about people who have poor nutrition, and whether that poor nutrition is out of what gets perceived by some as, laziness, whether that's a function of not having adequate resources to pay for certain kinds of nutritious food, or just lack of education, or whatever the cause may be. So I guess what I'm trying to highlight with this particular comment is, I don't think we want to go down a path where we're looking to blame individual Canadians for a communal challenge, and a communal challenge which is a function of a number of things and a number of policy decisions that have been made along the way in terms of what kind of healthcare resources are available, what kind of facilities are available, how many beds we do or don't have, how many respirators we do or don't have. This all, has put us where we are today. And it isn't the choice of some people not to be vaccinated. That's the sole point of, what at different times has been a real crisis. So I guess I just wanted to make that point, that I don't want us to go down the path of looking to sort of point fingers and blame people for things that I would rather be looked at as a collective challenge and found collective responses to.
Thank you, Dr. Baylis. We've gone a little bit over time, and so I need to draw this to a close. I want to extend my deep gratitude to our panelists for sharing their expertise with us today. I think this has been a very valuable contribution to public knowledge and for understanding and engaging what these current policy tension points are, as well as taking it even further. The recording of this panel will be available on the McEachern Institute's Facebook page by Monday for all to see. And so I just want to thank everyone for attending and for the great questions, and have a great afternoon, everyone. Thank you so much.
Thank you. Bye-bye. Thanks a lot.